So the next we are going to discuss is tuberculosis. The tuberculosis, it is caused by Mycobacterium tuberculosis. So remember, this bacteria was discovered by, it is also known as tubercle bacilli, and this bacteria, it was discovered by Robert Koch in year 1882. So who discovered the bacteria that causes tuberculosis? The answer is Robert Koch. So this Mycobacterium tuberculosis, remember, it is a strict rod-like bacteria that is strictly aerobic. That means that it needs oxygen to survive. So where does it survive? It survives best in the area of body with higher oxygen level, such as the apex of lung. Now, why does M. tuberculosis thrive in the apex of lung? Since the apex of the lung, remember, it has higher oxygen level, so that is why the bacteria, it prefers the apex of lung for its survival. The apex, remember, it favors higher oxygen tension, that is favorable for the aerobic bacteria. Apart from that, the blood flow in the upper lobe is relatively lower, that may limit immune system activity and allow the bacteria to persist. So due to the apex of lung that provides higher oxygen tension, that is favorable for the aerobic bacteria, and the blood flow that is relatively lower, that is why this tuberculosis bacilli, it prefer the apex of the lung. Now coming to what are the most common strains in human. In human, it is M. tuberculosis hominis. And in the past, M. tuberculosis bovis was due to the consumption of unpasteurized milk. Now, the which strain of M. tuberculosis is most common in human today? It's the M. tuberculosis hominis. The other strains include the M. microti, M. smigmatis, etc. Now remember, M. tuberculosis, it's a rod-shaped bacilli that measure around 0.5 micrometer to 3 micrometer in size. And remember, it does not stain with the usual gram staining method. Instead, we use special methods to identify it. What are the special methods that we use? It's the acid fast staining. So this method, it works because the bacterial cell wall, it contains the mycolic acid and other lipids, so that makes it resistant to decolorization by the acid and the alcohol. Other methods that we can use is fluorescent dye method. Culture method we can use is LJ method, and molecular methods. Apart from that, we can use the molecular methods like the PCR. Now, why do we use acid fast staining to identify the Mycobacterium tuberculosis? Since it contains mycolic acid, that is why we prefer to use acid fast staining. Now, the atypical mycobacteria, they are different from the M. tuberculosis. So they are classified based on how they grow. They can be divided into rapid growers or the slow growers. The rapid growers, they grow within 7 days. Example is M. chiloni, M. fortitudinum. Whereas the slow growers, it takes around 2 to 3 weeks to grow. So they can be photochromogens that produce yellow pigment in light. Other can be scotochromogens. So they produce pigment whether in light or in dark. Whereas non-chromogens, the non-chromogens are one that do not produce pigment. What is the difference between the rapid and slow growers among the atypical mycobacteria? The rapid growers, they grow in the 7 days, whereas the slow growers, they take around 2 to 3 weeks. Now let us discuss about the incidence and the HIV associated tuberculosis. We know that tuberculosis, it's the most worldwide, most common disease in the developing countries. The factors that increase its incidence, it may be malnutrition, poverty, and patients who are immunocompromised. So why is the tuberculosis still common in the developing countries? It is due to the factors like malnutrition, poor medical care, poverty, and immunocompromised condition. The HIV infected individuals, they have a higher incidence of tuberculosis. They can even develop the extrapulmonary tuberculosis that is more common in these patients. Now let us discuss the mode of transmission of tuberculosis. The tuberculosis, it can transfer through the inhalation method, breathing in droplets from the infected person's cough. It can spread through the ingestion, like drinking unpasteurized milk from the infected cows or swallowing infected sputum. Or it can transfer through inoculation through the skin from the infected tissue, or it can be the transplacental route, that is from mother to the fetus. So what is the most common way TB is transmitted? It's the inhalation method. The inhalation of droplets from the infected person cough, it's the most common way of tuberculosis spread. Now let us discuss how the tuberculosis, it spreads in body. It can spread either through the local spread, either macrophages, they can carry the bacteria to nearby tissue, or there could be lymphatic spread. The bacteria spread to the lymphoid tissue that can cause inflammation of the lymph nodes, that is the lymphadenitis. Or it can be blood route, that is hematogenous route. The bacteria spread through the bloodstream through the miliary tuberculosis. What is miliary tuberculosis? It is when the tuberculi bacillus, it spread through the bloodstream and it causes tiny lesions in the multiple organs. That is known as miliary tuberculosis. So in tuberculosis, remember the tissue changes we see, these are due to the body response to the bacteria, and not because the bacteria produce the toxin. So this response, it involves cell mediated hypersensitivity, that is type 4 hypersensitivity, and the immunity. So do tubercular bacilli, they produce toxin that cause tissue damage? The answer is no. The tissue changes, they are due to the body response to the bacteria. So these responses, they can be triggered by various lipids that are present in tubercle bacteria. That could be mycosites, or they can be glycolipids. Now what Robert Koch found that he found that the body response, the body reaction to the tuberculous bacilli, it is different in first time infection compared to when there is a repeat infection, that is the secondary infection. So when the tuberculous bacteria, they are injected into skin of the healthy guinea pig, there is no reaction for 10 to 14 days. So after this, a nodule formation occur, that ulcerates and heal poorly. So this is similar to the primary tuberculous bacillus in the children, although in the children it heals better. Whereas if the tuberculous bacteria, this is the primary infection. In the secondary infection, if the tuberculous bacilli, they are injected into guinea pig already infected with the tuberculosis, the site become indurated, dark within 1 to 2 days, and it ulcerate and heal quickly. So here the lymph nodes that are not involved. So that is known as Koch phenomenon. So it is a quick response and healing at the injection site in the guinea pig previously infected with the tuberculosis bacillus indicate the hypersensitivity and the immunity. Now what is the role of CD4 T lymphocytes? So hypersensitivity and immunity, they are closely related and they are triggered by these CD4 T lymphocytes that are sensitized to tuberculous bacilli antigen. So they will release lymphokines that will increase the microcidal activity of the macrophages. So what is the test that we can do for the skin test in the tuberculosis? That is the tuberculin test, or it is also known as Mantoux test. So here what we do is we inject a small amount of tuberculoprotein into the skin. So a positive test that shows indurated area of more than 15 mm after 72 hours, that indicates a cell mediated hypersensitivity to the tuberculous antigen. So what does a positive Mantoux test indicate? It indicates cell mediated hypersensitivity to the tuberculous bacillus antigens. Now the immunization against the tuberculosis that we can give is BCG vaccine. So that induces cell mediated immunity and delayed hypersensitivity. Now let us discuss the evolution of the tubercle. So what are the changes that occurs when the tuberculous bacilli it enters the tissue? So first of all, the initial response is the neutrophils. They respond first, but they will be quickly destroyed. Then there would be macrophage infiltration after 12 hours. So the macrophages will dominate after the 12 hours. The macrophages, they try to phagocytize and engulf and kill the bacteria. And if they die, more macrophages, they are recruited. There would be T and B cell activation. So CD4 T cells, they cause delayed hypersensitivity reaction, and B cells, they produce antibodies. So there would be epithelioid cells. So the macrophages, they transform into the epithelioid cells that forms the granuloma. So some macrophages, they fuse with the multinucleated giant cells, either the Langhans cells And epithelioid and the giant cells, they together form granuloma that are surrounded by the lymphocytes, plasma cells, and the fibroblast. So within 10 to 14 days, the center it undergo the cheesating necrosis, so it becomes cheesy and high in the lipids and forms a soft tubercle. So what is granuloma? So granuloma, remember, it is a cluster of epithelioid and giant cells that are formed in response to the tuberculosis infection. Now what is the fate of granuloma? The granuloma can liquefy and form cold abscess. It can form sinuses in the tissues like bones or the lymph node. It can undergo calcification over time. So what happens to granuloma over time? Remember, it liquefy, form sinuses. It can enlarge with fibrosis or undergo calcification. Now what are the types of tuberculosis? Tuberculosis can be primary tuberculosis or it can be secondary tuberculosis. So primary tuberculosis occur when the person is infected with tuberculosis for the first time. So it is also known as Cohen complex or childhood tuberculosis. So what is the primary tuberculosis known as? It is known as Cohen complex or childhood tuberculosis. So the Cohen complex, it includes the pulmonary component, lymphatic vessel component and lymph node component. So what are the component of Cohen complex? Pulmonary component, lymphatic vessel component and the lymph node component. So the Cohen complex, it consists of tuberculous granuloma with the cheesating necrosis in the lungs, lymphatics with the phagocytes that contains bacilli and the lymph node that shows cheesating necrosis. So remember, what is the fate of the primary tuberculosis? So most primary tuberculosis, they heal by fibrosis. Over time they may calcify. Some may grow and spread to the other part of body that cause progressive primary tuberculosis. The bacilli, it may affect the bloodstream, leading to primary miliary tuberculosis, affecting the organs like liver, spleen, kidney, brain, and the bone marrow. Second is the secondary tuberculosis. It occurs in the individual who have been previously infected, and it is also known as a post-primary or chronic tuberculosis. So what is the other name of secondary tuberculosis? It's the post-primary or the chronic tuberculosis. So what is the source of infection here? The source can be exogenous reinfection or there would be reactivation of dormant primary tuberculosis lesion. The most site in the apex of lung, and it can involve a tonsil, pharynx, larynx, small intestine and skin. So where does the secondary tuberculosis most commonly occur? It occurs in the lung apices. So what is the fate of secondary pulmonary tuberculosis? The lesion may heal with fibrous scarring and calcification and may cause progressive secondary tuberculosis. With complication causes tuberculosis, caseous pneumonia and the miliary tuberculosis. Now what are the clinical features of tuberculosis? First of all, there would be productive cough, the persistent cough that produce mucus, sometimes containing blood. The term we use is hemostasis. There can be fluid accumulation. The term we use is pleural effusion in the pleural cavity that may cause chest pain and difficulty in breathing. There would be shortening of breath The term we use is dyspnea. Or difficulty in breathing while laying flat, the term we use is orthopnea. Or on the chest X-ray finding, you may see conditions like pleural effusion, nodularity, and miliary or diffuse infiltration in the lung parenchyma. So what are the some lung-related symptoms of secondary pulmonary tuberculosis? Productive cough, hemostasis, pleural effusion, dyspnea, orthopnea, and the chest X-ray changes. What are the systemic features? One can see is the fever, night sweats, fatigue, loss of weight, secondary amyloidosis. That could be the systemic feature. Now, how can you diagnose the tuberculosis? You can do is the Mantoux skin test. You can do is the sputum test for the acid-fast bacilli. You can do is complete hemogram that will show lymphocytosis and raised ESR that suggest a inflammatory response. Apart from that, you can do is chest X-ray where you may see hilar nodule and other parenchymal changes. Apart from that, you can do is FNAC of the enlarged peripheral lymph node that you can do. So what could be the cause of death in the pulmonary tuberculosis? That could be due to the pulmonary hemorrhage, bleeding that can occur in the lungs, failure of lung to function adequately leading to pulmonary insufficiency, or there could be sepsis. So life-threatening infection that spread throughout the body due to the disseminated miliary tuberculosis, or there could be right-sided heart failure that can result from the chronic lung disease. The term we use is cor pulmonale. Or secondary failure, it can occur due to the deposition of the amyloid protein. So what are the some causes of death in the pulmonary tuberculosis? It could be pulmonary insufficiency, pulmonary hemorrhage, sepsis, cor pulmonale, or the secondary amyloidosis. So this was all about the tuberculosis.